Great, good afternoon. Welcome to this afternoon session. It's fantastic to be here. And we've got an excellent panel. I'm glad it's not a manel. That's always good. And we're going to be talking about a range of issues from a lot of different contexts. My name is Andrew Scheiber. It's great to be here with you. And my colleague over here, Tracy, will introduce herself in a moment. And what's quite encouraging and interesting about the session is we will cover a diverse range of topics, from around improving retention on OAT to some data on long-acting buprenorphine, as well as some information from meta-analysis, and also some harms relating to mental health services. And also, we do have one apology of a person who's not joining us. Is that correct?
Yes, but I'm not sure.
Okay. So we're going to start with our first person. Tracy, I'm going to hand over to you.
Hi, everybody. Welcome to this fantastic session. My name is Tracy Swan, and it's my pleasure to introduce Tatiana Fomenko from the Alliance for Public Health in Ukraine, who will be talking about improving access and retention on opioid agonist therapy in Ukraine.
Good afternoon, dear colleagues. My name is Tatiana Fomenko, and I work for International Charitable Foundation Alliance for Public Health, based in Kyiv, Ukraine, in a research project on expanding access to opioid agonist therapies among people who inject drugs in Ukraine. Our project is implemented in collaboration with the Yale School of Medicine, founded by National Institutes of Health USA. And today I would like to tell you about our work in Ukraine. So first of all, I have to mention that Ukraine leads in Europe in terms of HIV prevalence, and one of the main drivers of HIV transmission is injecting drug use. In Ukraine, we have opioid agonist therapy, methadone and buprenorphine, and we know that this is the worldwide recognized therapy for people who inject drugs, and an evidence-based means of HIV, HCV, and TB prevention. As of January 2023, less than 7% of people who inject drugs were covered with OAT in Ukraine, while WHO recommends the coverage of at least 20% for effective prevention of HIV transmission among people who inject drugs. The beginning of Russia's large-scale war against Ukraine led changes in all spheres of life, including access to services and changes in the needs of people who inject drugs. So there is the need in evidence-based approaches to improve the quality of opioid agonist therapy services in Ukraine. Fellow colleagues from Yale School of Medicine trained OAT for providers from all 25 regions of Ukraine on how to use the network for the improvement of addiction treatment approach for process improvement that helps to scale up OAT program in Ukraine. The network for the improvement of addiction treatment is an evidence-based approach of process improvement that helps healthcare providers to improve services, learn innovation strategies, and remove the barriers within the existing financial and administrative resources. There are 4 aims of NITEX, of the model. They are reduce waiting time, increase admissions, reduce no-shows, and increase continuation rates. So in every of 25 regions of Ukraine, we have created a change teams with the leader of chief narcologists and OAT providers. And every region had to identify the main barriers that, and to find the ways to overcome these barriers for better access and retention on OAT program. So there were 3 main types of change projects. The first one, access. We were working on increasing capacity. Retention. We were working on disciplinary control on OAT sites, and improving access to HIV, hepatitis, and TB diagnostics and treatment. And the third type of change projects was access and retention, and we are working on dispelling myths about OET and take-home dosing increase. So the team of 4 Ukrainian colleges had monthly online meetings with chief narcologists for counseling, process improvement, and troubleshooting. There were 5 learning sessions with the Yale School of Medicine team in 2022 and 2023. On this meeting were presented our colleagues from Yale School of Medicine, our chief narcologists, OT providers, and the Ukrainian team of colleges. So about some results that we have received. The number of these results are as of September 2023. So number of OET patients increased from 90,919 in January 2023 to 20,678 in September 2023. The share of take-home dosing constitutes 88.5%. Both OAT and ART received 29.7% of clients, which constitutes 97% of all OAT patients living with HIV. The number of OAT patients living with HCV has changed from 56% to 52%. And among internally displaced OAT patients, there was no interruption in treatment among 99% of them. So here I would like to present you the map of Ukraine. And here you can see the coverage with opioid agonist therapy based on number of people who inject drugs as of September 1st, 2023. The green color means that in these regions, the coverage is more than 10%, but it's still less than recommended by WHO, less than 20%. The red color means that in these regions, coverage percent is less than 6. And on this map, you can see the national targets for 2023. And as of September 2023, we see that 2 regions have almost achieved the national targets, and the red color means that these regions are still working to achieve the national targets. So NIATEC's approach combines the process improvement tools and techniques that helps OET providers to lead successful process improvement initiatives. Using rapid cycle change, NIATEC's model contributing to access and retention in addiction treatment in Ukraine. And the next step is to continue increasing the number of OET patients in Ukraine and review and adjust the existing interventions and services for people who inject drugs due to the war in Ukraine. So I have no conflict of interest to declare, and I would like to say thank you to all my Ukrainian colleagues, especially from Alliance for Public Health, Yale School of Medicine, and Public Health Center of the Ministry of the Health of Ukraine. Thank you.
We have time for a couple of questions, and I have one for you. Even in normal circumstances, in the absence of a war, a 99% retention rate is amazing. How were you able to retain so many people in OAT? You said you retained 99%?
Yes.
How were you able to do that? That's incredible. Congratulations to you and your colleagues.
My colleague.
Okay, let me help my colleague. So she was talking about 90% of patients who were internally displaced because of the war. And during the overall, our retention is about 85%.
That's
But
incredible.
among internally displaced, it kept at 99%, due, and thankfully, to our colleagues from Public Health Center of the Ministry of Health of Ukraine, and also because of the network of all narcologists, like drug addiction specialists, which was created because actually of the war, and they were in touch and they were collaborating and keeping networking in all the messages and everything, and that's how they kept all the records and all the patients in the program.
Well, congratulations to you and your colleagues. And are there any questions from the audience? All right, Matt.
Just to say, a friend of mine, Igor, was in Kherson all the way through the Russian occupation, and the fact that you continued prescribing buprenorphine to him for the vast majority of that time, I think is absolutely remarkable. And I just wanted to really commend you for that commitment to the human rights of people who use drugs. Really, congratulations.
Thank you.
Anybody else? All right.
Thank you so much.
Thank you. Now we're going to move from one context to another one, and we're going to have Tara Gomez from the Unity Health Toronto, talking around characteristics, treatment patterns, and retention with extended-release subcutaneous buprenorphine for opioid use disorder, a population-based cohort study.
Thank you for that introduction, and I'm really pleased to be here today to be speaking about some of the work myself and my colleagues have been doing in Canada, trying to better understand how the extended-release subcutaneous buprenorphine has been provided, and looking specifically at dosing patterns and retention and treatment. Before I get started, I do think it's really important to acknowledge everybody who is living through the substance toxicity crisis in Canada, where I come from, but also around the world. We've heard so much about the impacts of this crisis all over the world so far in this conference. And I also want to recognize that people find benefit, people who use drugs and people with opioid use disorders find benefit in a range of services, including both harm reduction and treatment, which I'll be talking about today. I also really want to acknowledge my appreciation for the people with lived expertise who contributed to this work throughout its completion. They advised us and provided so much expertise, both on how we would go about designing this study as well as its interpretation, and we really couldn't have done it without them. I have no conflicts of interest to declare. All of this work and the work I do is funded by our provincial and federal grants. Just for context, to give you an idea of what the drug toxicity crisis looks like in Canada, in Ontario, which is the most populous province in Canada, we have been seeing a really alarming trajectory of opioid toxicity deaths. We were already concerned throughout the 2000s as the numbers began to rise, and then in 2016, we began to see this acceleration in opioid toxicity deaths that only worsened as the pandemic arrived. And as you can see from this figure, this is postmortem toxicology from opioid toxicity deaths in Ontario. This is a crisis of fentanyl, and fentanyl that is now in our unregulated or illicit drug supply. So that is what has been driving all of the deaths and the increases in deaths that we have been seeing since 2016 when it first arrived in our unregulated drug supply. And so now we're in the point in our province in Canada where 1 out of every 30 deaths that occur are from an opioid toxicity. And if you look at people in their 30s, 1 out of every 3 deaths in that age group is from an opioid toxicity in our province. So when we look at toxicity deaths, we also have to think about who is being impacted. And we know that 2/3 of the toxicity deaths that have occur among people with an opioid use disorder. And we don't actually have a great idea of how many people have an opioid use disorder in Ontario or even across Canada, but we do know that we have 70,000 people who are accessing treatment in 2022. So we have tens of thousands of people accessing treatment and many more with an opioid use disorder. And we have 2 first-line agents, which I'm sure everybody here is quite familiar with, which are methadone and buprenorphine naloxone combination. And they're first line, but they do have challenges that come with them, primarily being that they require frequent visits to pharmacies and healthcare providers. And there are limits on the take-home doses that are available for people. Second, create challenges around accessibility and retention for these treatments, in particular in rural and remote regions, people who are trying to balance accessing treatment with employment, and obviously impacts on people's quality of life. When we've looked at retention in past studies, we've seen that on average, people discontinue these first-line agents within about 6 months. So when the extended-release buprenorphine product, Sublocade, which is the version that is approved in Canada, came to market, there was a lot of benefits seen here. This is an injection that's meant to last 26 to 28 days, and so would have that benefit of people not having to have this frequent contact with the healthcare system. But we also knew that we needed to get healthcare providers on board who would prescribe this and find healthcare providers to administer it to make sure that its accessibility was high. So this product first became available in Ontario in February 2020. And for those of you who may not know, to be inducted into Sublocade, first people have to have about 7 days at least of the buprenorphine naloxone product. And then they get 2 doses separated by that 26 to 28 day window of the 300 milligram formulation, after which point the monograph suggests that people's doses are dropped to 100 milligrams. And I'll talk about why that's important in a minute. But based on all of this knowledge, we really wanted to look at a few factors, including what was the accessibility and uptake of this new product, what was retention, and then what could we learn about treatment patterns. So we did a population-based cohort study. We looked at all people newly starting Sublocade between April 2020 and March 2022 who are adults in our province. And we looked at a number of different factors. We looked at monthly trends of initiation, we looked at demographic and clinical characteristics, time to discontinuation, as well as treatment patterns. So we looked at the dose patterns people had, whether they are being co-prescribed other medications, and their injection frequency. And this is what we found in terms of trends. So we certainly saw after this product's arrival in our province an uptake of the Sublocade as one form of OAT. And while this looks, like a considerable uptake, when we look at the percentage of all OAT, Sublocade in March 2022 only represented 6% of all OAT prescribed. So still quite a small fraction of all treatment that is being accessed by people in Ontario. On average, people tended to be slightly older, 38 years, compared to the first-line agents, slightly less likely to be male, 58% male, but we did see this concentration in rural and northern parts of our province. And the northern part of Ontario is the more remote part of the province as well. So we really did see this concentration of a high degree of initiation in those parts of the province. However, when we looked at time to discontinuation, we found that it was very similar to the first-line agents. So on average, the median time to discontinuation was about 6 months. And this didn't vary by urban and rural location or northern and southern parts of the province, such that about 1/3 of people continue to be on treatment after a year. So quite similar patterns of retention seen for Sublocade compared to methadone and the buprenorphine naloxone products. But we also saw some interesting elements related to dose. So not surprisingly, almost everybody initiated at 300 milligram doses. But then we looked at people with 3 or more injections. So those people who would have been eligible to have their dose reduced to 100 milligrams at their 3rd injection, we found that 19%, so about 1 in 5, never had a dose reduction. And a further 29% who did have their dose reduced had it increased again at a later date to that 300 milligram formulation. And that's important because we certainly heard from people that that 100 milligram dose was not always adequate to meet their needs, and that they would go into withdrawal, probably because of the high degree of fentanyl exposure that we have in our population and the fact that the 100 milligram dose may not be sufficient to prevent withdrawal for people who are receiving it. We also saw the median time between injections was 28 days, which aligns very closely with what we would expect. However, we did see that about 16% of people had an injection frequency that was shorter than 26 days. It tended to range between about 14 and 26 days. And so that again speaks to the fact that we heard from many people that near the end of their 26-day window, they were not getting the full effect anymore. They were experiencing withdrawal, and there was a need for more frequent injections than what was recommended in the monograph. We also looked at supplementation with buprenorphine naloxone. So not surprisingly, almost everybody had buprenorphine naloxone before initiation for about 7 days. That was the induction phase. But we also saw that about half of people continued to get Suboxone during treatment, and about 1/3 of those people had it 14 days or more after starting treatment, which is indicative of people kind of topping up their dose if it was not sufficient with the Sublocade. And again, something that we had reiterated to us from the people with lived expertise who had been treated with Sublocade been telling us that they were receiving the buprenorphine naloxone to help prevent that withdrawal, especially later on in that 26-day period. I do want to mention a couple of notes. One, that we don't have in-hospital prescribing data, so we can't look at new starts in hospitals, although the majority of Sublocade initiation in Ontario would be happening in community settings. And we can't look at off-label dose adjustments. And this is important because one person in particular who was part of our study team said that they went down to 100 milligrams and it wasn't enough for them, but 300 milligrams was seen to be too high. So their physician was actually getting them dispense the 300 milligram Sublocade, but only administering approximately 200 milligrams of that. And so, while that is certainly a practice that we have heard is happening, it's not an ideal practice when you're having to eyeball on a 300 milligram injection what is approximately 200 milligrams so that people can not go into withdrawal but get the right dose. So just in closing, our hope is that this work has helpful implications for people who are looking at these novel treatments. I think there's a real opportunity here for improved accessibility, particularly we're seeing its concentration in more rural and remote parts of our province, where we can really help support people accessing treatment who may not have good access to pharmacies. But we do see that duration and retention is similar to other traditional OAT, and that perhaps the dose adjustments that are recommended by the manufacturer are not meeting the needs of people, especially people who are being exposed to fentanyl in the unregulated drug supply who have very high tolerances. And finally, what ties in with this is the co-prescribing with buprenorphine naloxone, where we did see a fairly high degree of that, which again suggests that perhaps Sublocade alone, at the doses available and the frequency of injection available, may not be meeting the needs of people with these very high opioid tolerances. And so that's kind of an avenue for further research for us to really understand the effectiveness and safety of the supplementation with buprenorphine naloxone and better understanding the real-world effectiveness of Sublocade. So I'll just close here and thank all of my co-authors who were really pivotal in helping us with this work. And I'm very happy to take any questions if there are any.
So before I open it up to the audience, from your work, any things that you would highlight the researchers that are planning to implement long-acting depot buprenorphine in low middle income settings should be aware of and should be maybe monitoring from when they start based on what you found?
Yeah, I mean, I think what struck me the most, and in speaking with people who also were being treated with these newer formulations, is that I think we need to really recognize that some people may not find that they're really working to prevent withdrawal, and we need to make sure that we're listening to people who have opioid use disorders who are being treated with these medications to make sure that we have some flexibility in how they're provided, because there's a massive opportunity with these products to not have that over-reliance on daily or every few days a week visits to pharmacies. But in order to do that, we have to actually make sure that it's working. And in Ontario, with the way these products are listed on our formulary, there are pretty tight restrictions on that injection frequency. So it specifically says, 26 to 28 days. And pharmacists are hesitant to use a shorter window because they're worried they'll get audited and they won't get paid by the government. So if you impose very strict requirements based on the product monograph, you may actually find that you're not allowing healthcare providers and people who are actually accessing treatment to have that flexibility to adapt this to their needs based on the tolerances that exist within different regional settings.
Thank you. I think we have time for one or two questions from the floor. Yes, please.
Hi, Todd Corthus from Oregon Health and Science University. I was just curious regarding the uptake in rural areas. In many rural areas, there's decreased access to start. Were you able to stratify those assessments of uptake by rural versus urban, and was there a difference?
Yeah, I don't have it presented here, but we definitely did see a higher acceleration. We actually replicated some of this work elsewhere across Canada as well, and we did see a higher acceleration at a higher population-adjusted rate in rural areas. So it really does demonstrate that there has been a really concerted effort in rural parts of Canada generally to try and get people access to this, because people see the value and the other barriers that have existed historically with other forms of treatment. So, we are seeing that, and I guess the next question is, how do we make sure it's working, and how do we make sure we can help people stay in treatment if that's the form of treatment that's most accessible to them?
Just with the, sorry, Joss Solone, GP from Brisbane on the Combi Clinic. With discontinuation of the injectable format, I mean, it's got a longer half-life. Did you follow up people down the track 3 months, 6 months to see if they've gone back to injecting drugs or where they were and the speed in terms of behavioural change, orals versus injectables?
Yeah, that's a great question. I guess the short answer is no. We did define discontinuation as more than 56 days, so it was essentially defined as kind of missing 2 scheduled injections. So we tried to be quite relaxed in that to allow for some discrepancies in the data, but what we can't really tell very well in the health administrative data we have is exactly what happens next. And I think that's a really important next step. We know with methadone and buprenorphine, when people stop treatment, risk of overdose increases. There are a lot of other domino effects that can come with that. And we have to, I think, replicate some of that work now with Sublocade to better understand those risks as well.
Thank you. Anyone else on the panel? Yes, please, Alison.
Sorry, just a quick question, Alison Ritter. Do you have Buvidal available?
No, we were just talking about that in the panel before. We don't. It's not approved by Health Canada.
Thank you.
Great, thank you very much.
Our next presentation will be delivered virtually from Carolyn Taro, who's from the University of Oslo, Norway. And she will be delivering Show Us 50 Females Who Inject Drugs, and we will start a program, The Invisible Women Who Use Drugs in India.
Hi, everyone. Thanks. I'd just like a screen sharing property, please.
If it's not possible to get the slides up, is there any way that we could hear them? Because we have a presenter waiting to share her work with us. But I don't know if she can hear me.
I can. Can you hear me?
Yeah, I can hear you perfectly and we can see you. So maybe you can talk to us while we're waiting for your slides to come up.
Sure.
Thank you.
Sure,
Sorry about this.
No problem at all. So hello, everyone. I'm very grateful for this opportunity to present a peek into the part of my doctoral work, which focuses on the role of ICTs for persons who use drugs. This session will focus on women who use drugs in India. I'm also very happy that there's a panel discussion that's dedicated this year to women who use drugs. And before I begin, I want to acknowledge and appreciate all participants in my research for sharing their stories and intimate space with me. And I have no conflicts of interest to declare, and ethical approvals have been obtained from respective boards. Okay, I'm going to try and share my screen now. Is this visible to everyone?
We can see it perfectly.
Thank you. So healthcare for women has historically been an extension of healthcare for men. The distinction being mostly biological. Gaps exist in data collection and use for women's health. And this is also true for women who use drugs. In India, for example, data reference to women who use drugs talks about prevalence of heroin use in combined population of men and women. There's underreporting, and there's this notion of women as caretakers of men who use drugs, or even drug dealers. Addressing this gap is essential, mainly because 1/3 of 275 million people who use drugs globally are women. They're at higher risk of HIV infection, HIV hepatitis infection, emergency care, and also stigma and discrimination and intimate partner violence. So the objectives of my study was to understand how gender norms influence harm reduction care and the interplay between information and technology in harm reduction care that women seek. I did a qualitative interpretive study, and in 2 states of India, and had 17 interviews for focus group discussions and relied on field notes from several informal discussions. Essential ethical considerations were made. The findings highlighted that women who use drugs are not merely a female version of women who use drugs, or men who use drugs, excuse me. In large cities of India, persons who use drugs under the National Harm Reduction Program are known to be migrants who travel across states in search of a job and are formerly just known to be street-based users. So that was the assumption. However, trends have changed and more people are home-based, but this is especially true for women. The case of home-based women who use drugs in India is riddled with gender roles. Women are assumed to be carers of family and carers of men who use drugs. And this expectation intensifies multifold, where their inability to care attracts much more criticism. So they're challenged, they're expected to care, and despite and unable to do that as a woman who uses drugs. Moreover, their lifestyle choice reflects not only on their reputation, but that of the family. Even in matriarchal states of India, there's a subtle patriarchy in practice where women are not protected from this perception of immorality. And this makes it difficult for them to access health. They don't want to show what they that they are drug users. And even if the family members come to know of their states, they're not allowed to leave the house to seek health care. The question then was, how do the women access some care? And the response I got was, why are the men in the home, of course? And this was only pertaining to what was available as a spouse program. Current harm reduction programs are designed to trace and look for spouses of users. And the care the woman receives is then dependent on information that partners give to spouse peer educators, and really dependent on the skill of this peer educator to divulge such information. So this really excludes unmarried women who use drugs, home-based sex workers who use drugs, or young girls as well. For women who do gather this courage to reach harm reduction services, barriers work to keep them away. Currently, the women in our study have no access to a comprehensive integrated healthcare service. They are void of reproductive health services and affected by sexual and gender-based violence. They also encounter lack of privacy. A woman who comes to a consultation has literally a public display of what she's about to say. A harm reduction consultant who's a user herself says you have to go to the same doctor and stand in the same line, but there's just random people around, the team and the counselor, etc. They also prove to be unsafe spaces for women. Women in the study feel far from comfortable. They're harassed and confronted by other women who accompany male users, but also they are sexually coerced by male users into coming in to one person said, they have the guts to ask me directly for sex because society has made it as such. That's a label. I have no moral compass just because I'm a drug user. In saying that, many express the need for women-centric spaces. So I explored this more, and in looking at a couple of pilot programs where women-centric services were implemented, we saw that these services were divided into three parts, namely women who injected drugs, women sex workers, and the transgender population. These structures or these clinics are physically separated structures, and so they expected women to visit each of these clinics. So this first of all is a cumbersome. So it's a problem for several reasons, especially if a user is a woman who uses drugs, but also in some cases a transgender woman, but also then a sex worker. So first of all, it's cumbersome and a financial burden for a woman to physically visit 3 different clinics across the city. Furthermore, each clinic is connected to individualized health information systems with separate metadata modules. And what this means is that if the woman visits one sex worker clinic, she is included in the system for this clinic and with the information about the condoms and the treatment for sexually transmitted infections. But if she's also a drugs user, she's then referred to a separate clinic and her data is entered into a separate information system. This would be fine if, these systems were interoperable or they spoke to each other, but more often than not, they're not. So what happens is that the drug use data is often absent. One of the program managers demonstrated this with the software when he said that, there's a space to say she's a sex worker, there's a space to say, a second space to say that she uses drugs, but there's no added variables in this sheet to say anything more about the drug use. So then the impact of this categorization then in practice is that when clinics refer users to a specific clinic based on their assumption of whether this person is either or, they assume that they cannot be both. And in reality, sex workers who use drugs come to clinics for condoms, health information, and they refrain from going to drug use clinics because of the label that's associated with it. This really talks to the way in which programs are designed and thereafter funded. During one of the focus group discussions, harm reduction consultants spoke of this effort that they had to put in gaining funds. The health official said, show us 50 female injecting drug users and we will start a program. Show them to us physically and we'll start it. But funding for such programs we know is obstructed by this lack of numbers of women attributed to social issues, to lack of safe spaces, to additional informational mishaps in program and health information systems design. So really, in summary, I want to say that addressing gender discrimination is more than really gathering data through sex disaggregation. While we know that gender norms create access barriers to harm reduction care for women, including discrimination and harassment at healthcare settings, it's really insufficient to just say women-centric services are required. An intersectional program and health information designing is essential, and we need to ensure that women is seen as a whole and not as categories of risk. Addressing these can really improve quantitative and quality of data on women who use drugs and hopefully provide evidence required for program implementation and policy change. My study was limited to 2 Indian states, so not really generalizable. The study focused on harm reduction services in tangent with National Health Program and not private care, so there could be more people that were left out, and the lack of time meant I couldn't speak to people from other gender types and other social contexts. Thank you very much for your patient listening. I'll be happy to answer questions today or via email. Thanks very much.
I hope you could hear the applause. I know Zoom presenting is rough and you often don't get live feedback. And are there any questions? Well, thank you so much for that presentation. It's so important to have insight in what is invisibilized. Thank you. One more hand of applause since it was Zoom.
Thanks very much.
Thank you. We'll now call up our next speaker, who's Kriana Bharat from the National Drug and Alcohol Research Centre from Australia. We'll be talking on agreement between self-reported illicit drug use and biological samples, a systematic review, and meta-analysis. Over to you.
Thank you so much, and good afternoon, everybody. I'd like to start by acknowledging and thanking the participants of the studies that were included in this review, as well as the co-authors and the funding bodies, and just to note that I have no disclosures to declare. Studies of illicit drug use often rely on self-report, but the reliability of self-report measures is often questioned. Biological testing is often considered a more objective measure of drug use, but they are not perfect, and discrepancies when compared to self-report cannot always be attributed to misreporting of use by the individual. To date, evidence for agreement between self-report and biologically tested drug use has been limited to specific populations and self-report instruments. So we conducted a meta-analysis examining these measures, examining the evidence for agreement between self-reported and biologically measured illicit drug use. We included all biological indicators, population settings, and major illicit drug classes So we excluded alcohol, tobacco, and novel psychoactive substances. We searched peer-reviewed databases and the grey literature and pulled studies published up to March 2022 that reported 2x2 table counts or agreement estimates comparing these measures. From just under 8,000 studies, we extracted data from 207. And of these, some of the common characteristics were studies being published from North America and Western Europe, urine being the most common biologic reported, self-report most often being collected using either a single question or experimenter-devised scale as opposed to a validated instrument, and cocaine being the most commonly reported drug type. In terms of risk of bias, we used the QUATIS-2 and found most domains were rated at low risk. However, over half of all studies had a high risk of bias relating to the reference standard, which in this case is the biological measure. For the sake of time, I'm going to be focusing on the results relating to cocaine. Overall agreement varied, with kappa values considered good for hair, very good for urine, and excellent for saliva. When we looked at other measures of agreement, specifically sensitivity and specificity, we found that pooled estimates of specificity were all excellent, but cocaine had sensitivity estimates that ranged from poor to good. When we conducted subgroup analyses of these measures, we uncovered some useful insights. This is a lot on a table. I will focus you in on these two sections. So in the middle, we have sensitivity, and on the far right, we have specificity, and it is important to consider both of those in tandem. So we found that sensitivity estimates were good among research studies that were classified as having no consequences for reporting drug use. But among studies conducted in criminal justice settings, we found that sensitivity estimates were poor. So this demonstrates that the context in which these measures are collected are of critical importance when we're thinking about how self-report and biologically tested drug use agree. In considering other sources of heterogeneity, we found that longer timeframes of self-reported drug use tended to provide better agreement. And this might suggest that people are more comfortable reporting drug use perceived as being more temporally distant to the time of self-report. We found that agreement tended to be higher among cohorts with a higher proportion of people who use drugs. This might also be expected when studies are recruiting people based on their having dependence or having acknowledged high levels of drug use prior to entering into the study, so the fact that it was a condition of entry into the study. We also found that agreement tended to be higher in studies when people were informed that they would be tested prior to providing self-report. As I said, this is just a small slice of all the findings that we had. I would like to refer you to the paper for a range of other findings. Please don't hesitate to get in touch, and I look forward to your questions. Thank you.
Thank you. We have time for a question. Flo?
No, go ahead.
Alison, then Matt?
Thanks very much. Very nice paper. Were there differences between the substances? Like you've just shown us cocaine, but can you comment whether one of the substances had a higher concordance than others?
So overall agreement across most of the major drug types were excellent. So the overall agreement. Sensitivity and specificity did vary between the different drug types. So there's quite a lot of numbers relating to that. So yeah, refer you to the paper for that. Thank you.
Thank you very much for your paper. I'm just wondering, did you have a sense at the end of whether it's actually worth doing biological testing within treatment? I mean, does it actually add to the process or add to research? I was reading a paper the other day that said actually self-reporting is as accurate as biological testing, but biological testing brings both stigma and a huge amount of cost into the process. And I think when the results seem to be almost the same, it seems to be the lack of trust of people who use drugs that is the key determinant rather than actually effectiveness. I wonder if you have any comments on that in your own study.
Yeah, really important point and question, and I do think it is really dependent on the context in which those measures are being collected. In treatment settings, yeah, there's obviously some sort of discrimination associated with those collections rather than the self-report. I think it also, in thinking about the aspect that I wasn't able to touch too much on, but around the consequences for reporting and the impact that that has on the reliability of those measures, I think that that really has an impact on the usefulness of then collecting biological measures. Thanks.
How did you define no consequences in the research you looked at?
Thanks. So we a priori expected that willingness to disclose drug use would be impacted by the context and the setting in which it was collected. So in extracting, we looked at whether the purpose of the data collection, the people collecting the data, or the way that the reporting of drug use may be used subsequent to it being collected could lead to negative consequences for the individual and therefore leading to an underreporting of use. So it was a part of the extraction process and quite specific in that sense, but we had pre-teased out sort of specific settings, so criminal settings, roadside testing, cohorts of pregnant women, so those were teased out, and then it was among the remaining research studies, how could the consequences for reporting drug use be perceived?
Wonderful. Thank you very much.
Thank you so much.
Sorry, everybody. Our next presentation is Samantha College-Frisbee from the National Drug Research Institute in Melbourne, the impact of opioid agonist treatment on suicide and self-harm among people with opioid use disorder.
Thank you so much. Hi, everybody. So I am Samantha. I'm actually presenting this on behalf of Nikki Jones, who can't be here today. But I'm going to be talking about the impact of OAT, or opioid agonist treatment, on suicide and self-harm. So about 700,000 people die by suicide every year, and people with opioid use disorder are widely recognised as a major risk group for suicide and self-harm. In a recent systematic review, people who use opioids extramedically died by suicide at 8 times the expected rate. And in an Australian study, people with opioid use disorder were over 23 times more likely to be hospitalised with self-harm compared to matched controls without opioid use disorder. So we know that OAT is associated with improvements in quality of life, health, social well-being, linkage to care, and also reduces overall mortality and morbidity. And in another review, OAT engagement was associated with a 50% reduction in suicide mortality. But just as we expect with accidental overdose, we do anticipate that there will be some periods that are associated with differing levels of suicide and self-harm risk. So when looking at exposure to OAT in a UK sample, one of our co-authors, Priyanka Padmanathan, found that OAT was associated with a reduction in hospitalisations for suicide and self-harm overall. The first month after leaving OAT was associated with the highest risk of suicide and self-harm, so about 4.7 times and 2.6 times the risk, when compared to stable periods on OAT. And there appeared to be a slight increase in risk for both suicide and self-harm in the first month of treatment, but that effect wasn't significant. So we wanted to look at this in our large cohort of people on opioid agonist treatment in New South Wales. We wanted to see if we could corroborate Priyanka's findings, and we also wanted to see if we could look at these effects by gender and by self-harming methods. So the OATS cohort includes over 45,000 people who've been on OAT at any time from 2001 in New South Wales. Their information was linked to statewide hospital, emergency, mortality, and other administrative data sets. We'd basically complete information up to the end of 2017. So we wanted to look at these 4 discrete time periods: the first month of treatment, the remainder of time in treatment, the first month out of OAT, and the remainder of time out of OAT. And in our primary analysis, we only included those self-harm and suicide events that were coded as intentional, and then in a sensitivity analysis, we included events of undetermined intent. The methods were then categorised into opioid overdose, non-opioid overdose, violent methods, cutting or piercing, or other methods. So most of our cohort were men, as you might expect, and about 1 in 5 were Indigenous. Nearly 10% went to hospital for a self-harm event over the study period, and out of the 4,500 deaths, about 500 were from suicide. There were an additional 200 deaths that were self-harm of an undetermined intent. For self-harm presentations, women were more likely to present than men, and you can see that this was mainly due to an increased proportion of women presenting with non-opioid overdose, and to some extent cutting or piercing. And the overall rate of self-harm hospitalisation was about 19.2 per 1,000 person years. Suicide deaths were predominantly violent, followed by overdose using drugs other than opioids, and 9% of deaths by suicide were from an opioid overdose, or opioids were at least detected in the ICD codes. Men were more likely to die by suicide than women. However, women were slightly more likely to use drugs other than opioids to do so. When we looked at the crude incidence rate of self-harm, in the first month of treatment, the rate was 50.2 per 1,000 person years. This dropped down to 13.9 per 1,000 person years for the remainder of time in treatment, bumped up again to 54.7 in the first month out of treatment, and then down to 21.4 in the remainder of time out of treatment. So this was self-harm hospitalisations. When we compared these exposure periods, we found that the first month of treatment was associated with a 2.4-fold increase in risk, and the first month out of treatment was associated with a nearly three-fold increase in risk. The remainder of treatment was an increase of risk of about 40%. When we looked at suicide, the first month of treatment, the rate of suicide in the first month of treatment was 0.23 per 1,000 person years, and then the remainder of time on treatment was associated with, the rate of suicide and the remainder of time of treatment was 0.45 per 1,000 person years. In the first month out of OAT, the rate was 7.94. And this dropped down to 1.26 for the remainder of time out of treatment. When we compared these treatment exposure periods, you'll notice that the first month out of treatment was associated with a 16.4-fold increase in risk of suicide. The remainder of time out of treatment was associated with a 2.8-fold increase in risk. Sorry, I'll be quick. So retention on OAT is clearly associated with a reduction in self-harm and suicide. The first month of OAT, however, is a risk period for self-harm as well. The first month after OAT cessation is associated with a dramatic spike in suicide deaths and an increased risk of self-harm. Preventing suicide and self-harm during these risk periods should definitely be considered a priority. And this might be efforts to retain people on OAT or a more thorough analysis of self-harm at treatment. I think it's also important to highlight that the majority of overdoses were not actually due to opioids. I'm sure this is a bit of a tired debate, but OAT should not be withheld for concerns of intentional overdose. Thank you so much for listening.
Do we have any questions from the audience? Matt?
Sorry, nobody else is, I will. Did you look at why people left OAT? So was there any variation between people making a positive choice to leave OAT and detox, or people who were disciplinary discharged from drug treatment? Because I thought that would make quite a difference in terms of the suicide.
Yeah, that's a really great question, and also the question that I planted with our chairs, so perfect. The reason for leaving treatment, the way that that's coded in the administrative data is not great. So we wouldn't really consider it reliable. They would say people left treatment, but actually they had died. So we figured that was unreliable, and what we did was a sensitivity analysis. So sorry, to answer your question completely, we don't know, but we did a sensitivity analysis, and we extended the time in treatment to include the 6 days post last OAT receipt. And we found that in that 28 days after that 6-day extension, the risk of suicide dropped to about 5.5 per 1,000 person years. So unfortunately, in that 16.7 fold increased risk is probably a combination of people who have died by suicide and then don't return to treatment as well as people who leave treatment and then die by suicide.
Yes, please.
Thank you for interesting and very comprehensive presentation. I've noticed that you mentioned the mental health treatment as one of the services or maybe supportive therapies could be provided for those patients, as far as I understand. My question is, are we expecting if those patients were assessed psychologically and they undergoes with pharmacotherapy for depression, for example, or maybe antipsychotic, do you expect any change in this study or in their risky behaviors, including suicide or including overdose?
Yeah, so the question being, if we kind of did like a more thorough mental health assessment for people who are entering or leaving treatment, might we find a reduction in suicide, self-harm, and maybe overdose risk? That's a really great question. I don't think I have an answer, unfortunately. I would like to think so. I would like to think that there could be a greater linkage to care for people who are maybe more considered high risk, especially if they're leaving treatment. I think that first month, that increase in risk for self-harm, that's pretty interesting. And I think understanding that a little bit better and what OAT how that relates to OAT initiation will be really fascinating. But unfortunately, I don't really know the answer to your question, but I would hope that, yes, it would.
Thank you very much.
Thanks.
So it's also great to hear about new areas of future research, particularly into areas of self-harm. So please, I'd like to welcome Sean Fulade-Nulia from the Johns Hopkins University School of Medicine, who'll be talking on the impact of HIV provider training and support on substance use disorder screening and treatment in outpatient HIV care. Over to you, Sean.
Thank you so very much. I'd like to start by acknowledging the clinic staff where I work in Baltimore, our amazing patients, and my co-authors on this abstract. Approximately 10 to 48% of people with HIV in HIV care settings meet criteria for a diagnosis of substance use disorder. As we just heard, substance use is associated with increased morbidity and mortality from both HIV and non-HIV related causes, including overdose, suicides, and accidents. Medications for opioid use disorder, such as buprenorphine, and alcohol use disorder, such as injectable naltrexone, improve health outcomes. However, limited knowledge, comfort with, and lack of support for substance use disorder care has been reported by ID care teams as barriers to routine integration of substance use disorder care into HIV care settings. The RESTORE model is a substance use disorder HIV care integration model which utilizes a multi-component approach to support routine substance use disorder care screening and treatment in a large HIV care setting. Today, I will discuss the impact of this program on rates of substance use disorder screening and treatment in the overall clinic population. This program was implemented in the Johns Hopkins John G. Bartlett Clinic, which is a multidisciplinary infectious disease care clinic. It serves a predominantly minority population in Baltimore, Maryland. The RESTORE program had three core components. One, provider education through an initial buprenorphine waiver training. This was critical because in the US at the time, providers had to undergo 8 to 24 hours of additional training to be able to prescribe buprenorphine. This was followed by quarterly provider case conference discussions. To provide ongoing support, a clinician champion who was an HIV provider with an interest in substance use disorder received dedicated time to both provide substance use disorder care treatment and support other providers in providing this care. In addition, we hired a person with a lived experience of substance use as a member of the healthcare team to support patients in engagement. The program was implemented in January 2019. For this analysis, we used electronic medical record data, and we tried to estimate the causal effect of the RESTORE program on screening for substance use disorders and prescription of medications for opioid use disorder, focusing on buprenorphine or injectable naltrexone, and alcohol use disorder, focusing on injectable or oral naltrexone, acamprosate, disulfiram, or topiramate. We measured outcomes 1 year pre-implementation, January 1, 2018 to December 31, 2018, and 1 year post-implementation, April 1, 2019 to March 31, 2020, to give a 3-month monitoring period for us to actually begin to see the effect of the program implementation. We compared patients in our HIV clinic to patients in another HIV clinic which use the same electronic medical record. And we did this because the patients in the comparison clinic are intended to represent the experience of patients in the Bartlett Clinic in the absence of the Restore program. Because the populations are different, we adjusted for age, race, and gender, and we used a prior event rate ratio method to adjust for unmeasured confounders. What this does is it compares the rate ratio in the pre-intervention period between both clinics to assess for unmeasured confounders. If there are no unmeasured confounders, the rate ratio will be 1. If there are unmeasured confounders, it will adjust for this bias in the post-intervention period. These are the demographics of both the Bartlett Clinic and the comparison clinic. You will see that the Bartlett Clinic is much larger, with over 2,000 patients in both the pre-intervention and intervention period, whereas the comparison clinic only has about 700 patients. You will also see that the Bartlett Clinic overall is older. It's predominantly Black, as opposed to the comparison clinic, which is about 50% Black. And you will also see from the insurance distribution that patients in the Bartlett Clinic were more likely to be insured by Medicaid, which in the US is the insurance used by people of low socioeconomic status, versus the comparison clinic, where patients were more likely to have private insurance or self-pay, indicating a population with a higher socioeconomic status. These are our results. So in the Bartlett Clinic, you see pre-intervention compared to the intervention period. Overall, there were 17,000 clinic visits pre-intervention compared to 15,000 visits post-intervention. We see that the rate of screening pre-intervention was about 5.4 per 10 visits in the pre-intervention. It went up to 5.9 per 10 visits in the post-intervention. Overall, in the comparison clinic, rates of screening pre-intervention was 7.3 per 10 visits and went down to 7.1 per 10 visits. I think what is most exciting for us is that overall substance use disorder treatment rates went up from 52 in the pre-intervention in Bartlett compared to 82, so an almost double rate of prescriptions for medications for substance use disorders. You see that majority of these prescriptions were for buprenorphine for treatment of opioid use disorder, with a sprinkling of other medications for treatment of alcohol use disorders, whereas in the comparison clinic, rates stayed pretty stable. When we look at the causal effect of Restore on substance use disorder screening, we see an overall 11.9% increase in screening for substance use disorders overall, 11% increase in screening for alcohol use disorders, and a 12% increase in screening for other drugs. With regards to prescription of medications, we see a 78% increase in rates of prescriptions of medications for substance use disorders, but this was not statistically significant, likely due to the small numbers. Overall, implementation of the Restore model was associated with increased screening for substance use disorder by HIV care providers in an HIV care setting within 1 year of implementation. Additional work is needed to assess the long-term effects of this intervention. Thank you very much.
Great. Any questions from the floor? Perhaps while others are thinking, again, applicability of your model in a low-income middle setting, do you think you would do anything differently?
I mean, I think that's the beauty of this model. It's so simple. It involved training providers that were already existing in the clinic, and then incorporating a person with lived experience into the healthcare team, which I will say the biggest impact in our clinic setting was really reducing stigma, because our providers could see a person with lived experience as a very valuable member of the team that was helping them to do their jobs better. And I think because they felt it was easier to do their jobs, they were more likely to screen and then take on treatment for opioid use disorder or alcohol use disorder, as opposed to referring outside for that care.
I have a question. It seemed like a lot of people at the comparison clinic had to pay for things themselves. out of pocket. Do you think that also had a negative impact on uptake of treatment?
So possibly, but in the US, people living with HIV have the ability to receive coverage of services from Ryan White. So although they are indicated as self-pay in the database, that coverage is actually covered by Ryan White funds, which are federal funds that are set aside to provide care for people living with HIV.
So that really underscores the strength and benefits from the intervention.
I think it's a great intervention.
Wonderful. Thank you very much. A round of applause. So we're going to have Anna Conway, who is from the Kirby Institute from Australia, who will be talking about provider perceptions of de-implementation in OAT provision during COVID-19, considering social inequity in health.
Great, thanks very much. So the work that I'm presenting today is dedicated to the memory of Jude Byrne, who was a powerful advocate for the rights of people who use drugs. She really shaped the design and the recruitment of this study. So briefly, opioid agonist treatment during COVID. I'm talking today about de-implementation, which is the removal or reduction of potentially hazardous approaches to care, and to really differing extents across sites, across clinics in Australia. This de-implementation process during COVID involved the removal of supervised dosing, in-person appointments, and biological monitoring, such as urine drug screening. So for the study, we interviewed people who were providing opioid agonist treatment, so a mix of doctors, nurses, and service managers. And the study aims to explore how providers considered social inequity in the health of patients and the de-implementation of those restrictive OAT provision aspects during the pandemic. And I'll draw on concepts from normalization process theory. So at clinics where there was de-implementation, providers demonstrated adaptive execution to meet the different needs of people receiving treatment. And that adaptive execution is to promote social equity in health, but inherently results in unequal treatment. Providers that were less comfortable operating in the grey areas beyond the guidelines felt that this unequal treatment caused frictions between people receiving treatment and the provider, and between those people receiving treatment themselves. So like the experience of provider 14 here, who found that once people talk to each other in the clinics, then they're not happy with a perceived injustice and how they're receiving different treatments. The work around de-implementation caused some providers to reflect on their professional identity and the broader organisational identity. They were asking what the provision of opioid agonist treatment was for, who was it serving, what was the work involved. And Provider 30's clinic was offering home deliveries for opioid agonist treatment for people who couldn't attend the clinic during the pandemic. So that de-implementation of in-clinic supervised dosing opened possibilities to serve that wider range of people engaged with treatment and allow the provider to meet the needs of people with other health issues, to consider a wider range of needs that people receiving treatment have. So there was a disconnect between the treatment goals of providers and people receiving OAT that has historically been there in opioid agonist treatment provision in Australia, and that needs to be addressed through co-created treatment plans. So although lots of clinics do have mechanisms for patient feedback, but a system which has stayed relatively rigid for 20 years, the possibilities for change are limited. And what people are asked to feedback on and under what circumstances and the mechanisms for that are very varied. So any feedback system or evaluation should be patient-centred. Providers who find the work of the implementation more challenging need to access a supportive community of practice and have that experience from other providers to learn from. I want to thank all the participants and the Choice Study team, and especially the Community Reference Panel, who were involved in the design and recruitment for the study. Thanks.
Thank you. Wonderful to hear about the changes during COVID and people's providers' perceptions. Any comments reflections, questions? Great. Before I go to you, can you tell us what's happened with prescribing practice in Australia post-COVID?
Yeah, so already this was kind of at the these interviews were the end of 2020, so already towards the end of that interviewing period, you saw that some clinics were rolling back on what they had initially implemented. So there definitely wasn't any kind of, there was guidelines on what should be done, there wasn't any kind of standardized like the implementation process, so that each clinic, people could be receiving different treatments. So yeah, unfortunately, there was rolling back quite early on whenever the pandemic was perceived as, like, you know, not affecting Australia at that early stage. And then since then, it's really been, I suppose, differences at the jurisdiction level. So in Queensland, one of the states in Australia, they are now looking at revising the opioid addiction treatment guidelines in light of what's been learned from those last few years, but that's not the same across all the states.
Thanks very much, Anna. The term de-implementation, which I haven't heard before, so thank you for expanding my vocab, does that only apply to the sort of more punitive or repressive aspects of a healthcare intervention, or can you de-implement some progressive aspects as well?
Yes, so de-implementation is, it can refer to, it could be anything as like as innocuous as, you know, there might be changes in the preferred cancer treatment, so you de-implement one to then implement another. So it doesn't have to be, it's not particularly around, I'm using it to talk more about punitive policies, but it's more conceived as them being hazardous approaches to care, so what's maybe not seen as best practice anymore, it could be.
Yes, Naomi.
Hi, I was really, while we're talking about vocab, I was really interested in cognitive participation. Could you talk a little bit more about how you frame that and how you would hope it's used in the future?
Yeah, so cognitive participation, the idea that the providers should be, should understand the purpose of the changes in order to implement them effectively. So in some cases, especially what came through was that providers who believe that the work of their service might be, like there was one clinic who provided opioid agonist treatment but conceived their service as a harm reduction service. So they thought like the de-implementation of this is in line with what we want, what we conceive as being the purpose of our work. So I think that cognitive participation is to the potential of opioid agonist treatment facilitating people to live healthy lives rather than being something that needs to be controlled and participants or people who are receiving treatment need to be observed. So that kind of cognitive participation, whether or not that was in line with the process that was happening.
Great, thank you very much. I think then we'd like to thank all of the presenters, but one last round for yourself and everyone else, and we call this session a close.